So, good evening, everyone. Today, we are having our speaker, Dr. Vikram Nakhate. He is a senior retina consultant with over 10 years of experience attached to multiple centers around Mumbai. And he is specially attached to KM Hospital as an honorary retina surgeon since 10 years, as a medical director at Om Netralaya Ghatkopar.
Should I start, Rajni?
Yes, sir.
Okay. Thanks for the introduction, Rajni. So I'll be talking today on diabetic macular edema from understanding to treatment. At the outset, I'd like to thank Bayer for providing me this opportunity. These are the few disclaimers. So as we now know, it is expected that the global burden of diabetes will continue to rise, with India being the diabetic capital of the world, is now sooner going to be the diabetic retinopathy capital of the world also. And diabetic retinopathy is a significant cause of concern of preventable blindness. Moving forward, first we will see the anatomy of the eye. So this is a cross section of the eye where you could see the multiple layers, the cornea, iris, lens, and the innermost structure, the retina, which is of most important for today's discussion. As the center of the part of the retina, the macula gets affected in diabetic macular edema. So what is DME? DME is a leading cause of moderate to severe vision loss in patients with diabetes and a leading cause of blindness in working age populations in most of the developed countries. It can affect people with both type 1 and type 2 diabetes mellitus. DME is the presence of excess fluid in the macular area of the retina and can result in loss of visual function. DME occurs when the blood vessels in the retina leak fluid and proteins into the macula, causing the macula to swell, which in turn affects the visual function. The patient presents with varied symptoms such as floaters, a dark spot in the center of the vision, blurred vision, or reduced night vision. So, diabetic macular edema are basically of two types, focal and diffuse. In focal diabetic macular edema, the abnormalities in the blood vessels in the eye lead to focal DME. It is generally observed to be a milder of the two subtypes with less macular thickening, better visual acuity, and a lesser degree of retinopathy severity. Whereas diffuse diabetic macular edema, it's more severe with greater degree of retinopathy severity and leads to more macular swelling and vision blur than focal DME. If untreated, DME can lead to severe visual impairment. DME can occur in individuals at any stage of diabetic retinopathy. Badly controlled diabetes and untreated DME can lead to severe visual impairment and blindness. As you can see, a normal macula and a swollen macula with fluid accumulation in the macular area. Whereas in the right hand side, you could see a clinical picture with a yellow circle depicting microaneurysms and intraretinal hemorrhages, whereas the red circle depicting a lipid exudates often distributed in a succinate pattern around a leaking microaneurysm, with retinal thickening also noted. Vision loss in patients with DME can have life-changing consequences in their affecting their quality of life. The patients with DME are typically of working age, so vision loss that reduces the independence, productivity, and ability to perform daily functions can have a drastic impact on their lives. So, what are the basic factors that drive key mechanism behind the pathogenesis of DME? So, in diabetes, there is impairment in the vascular function, which results into the impaired retinal blood flow, causing hypoxia. So, hypoxia is the most important criteria, most important predisposing factor for VEGF release and PGF release, which causes neovascularization, increase in the inflammatory cytokine release, and vascular leakage and edema. This hypoxia also causes the PIGF activates the VEGF receptor 1 only, whereas the VEGF activates the VEGF receptor 1 and 2. Both of these, once this hypoxia causes increase in inflammation, releasing inflammatory cytokines, increase in the vascular permeability, causing endothelial cell apoptosis and pericyte drop-off, and neovascularization causing formation of new vessels. This all leads to breakdown of the blood-retinal barrier and vascular leakage and edema. So the treatment of visual impairment due to DME has evolved over time from laser photocoagulation started in 1985 to the first approved anti-VEGF ranibizumab in 2011. Aflibercept was first approved in 2014 with the latest one faricimab in 2022, and now we are awaiting the aflibercept 8 mg in the launch. So VEGF-A and PIGF, the placental-limiting growth factor, acts via the VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. VEGF-A acts via both the VEGF receptor 1 and 2, whereas PIGF acts directly on the VEGF receptor 1 and indirectly on the VEGF receptor 2s. Excessive activation of the VEGF receptor 1 and 2 can result in increase in the vascular leakage and edema and inflammation and pathological neovascularization. Aflibercept is the only globally available anti-VEGF agent that target multiple mediators of retinal diseases. As seen over here, brolucizumab and ranibizumab attack only VEGF-A, whereas aflibercept attack on multiple targets like the VEGF-A, B, and the PIGF. So even if the VEGF-A is completely blocked, VEGF-B and PIGF would still be able to bind their receptors and therefore contribute to downstream the pathological effects. So several molecular factors determine how a drug interacts in the body. So first, the binding affinity. So binding affinity determines how strong a drug interacts with its target. Lower the dissociation value is higher the binding affinity. So in this case, faricimab values are not available. They are reported to be comparable to ranibizumab. So aflibercept has the lowest dissociation value, and that is why found to be statistically higher VEGF binding affinity than brolucizumab and ranibizumab. Potency determines the required concentration of the drug to produce a defined effect. So it is basically the inhibitory concentration of the value. So the inhibitory concentration is of any drug is which assesses the value of the drug to achieve 50% of the concentration in that molecule. So lower the IC value is equal to the increased potency. So in this chart, if you see, the aflibercept has the lowest inhibitory concentration value, thus it has the increased potency compared to brolucizumab and ranibizumab. Faricimab data was not available. Half-life provides an insight into drug concentration in the body over a period of time. So higher the half-life, more the drug is available in the body for action. So again, aflibercept has the highest half-life compared to all other anti-VEGFs, 9 to 11 days. Binding target determines the downstream effect of a drug on the disease pathology. So brolucizumab and ranibizumab act on single target, that is VEGF-A. Faricimab acts on dual target like the VEGF-A and the ANG2. Whereas aflibercept act on multiple targets like the VEGF-A, VEGF-B, PIGF, and galectin-1. So in summary, VEGF-A, B, and PIGF are key drivers behind the pathogenesis of DME. Aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of retinal diseases. Several sources of evidence support anti-VEGF choice for patients, like the randomized clinical trials, international guidelines, real-world evidence, and our own experience. So it is important to provide timely and effective treatment for all patients with DME and ensure that vision gains are maintained in the long term. So for this, a study was done, Vivid and Vista, to show the impact of aflibercept in DME. So basically, this study was to study the safety and efficacy of the two dosing regimens of intravitreal aflibercept with macular laser. There were two groups. One group had received 2 milligram every 4 weeks, and the other group 2 milligram every 8 weeks after 5 monthly doses. The mean BCVA gain from baseline to week 52 in the groups was seen. From the first dose, only the improvement was observed with the first aflibercept injection. Patient received more than 8 injections through year 1 and maintained vision gains achieved during the initial loading phase. Across all the three, the patient treated with aflibercept gained an average more than 10 letters. At week 32 primary endpoints, aflibercept demonstrated superiority over Vivid and Vista. So the mean BCVA from baseline to reach to 52 weeks, it was seen with the laser group, the change in the BCVA letters were 0.9 to 0.7 letters, whereas in compared to the Vivid and Vista study, the gain in the aflibercept arm was more than 10 letters. So this study also said that delaying aflibercept treatment led to poor vision outcomes. So in this, the next term was the patients with the laser group were eligible to receive aflibercept PRN from week 100 if they met any predefined vision criteria. So even in this, starting late treatment, the vision improvement in the laser group was 1.6 to 1.4 letters, whereas those with the aflibercept arm, the vision gain was more than 10 letters. Can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? So there were two studies done, Hirano et al. Study. This study was done to assess the efficacy of a 2-year treatment extended regime involving aflibercept injection with the longest treatment interval of Q16 with adjunct focal grade laser. So the mean BCVA change in the baseline was 6.1 ETDRS letters, and 30% of the patient completed a 2-year follow-up. It was seen in 66.7% of the patients were on Q16 treatment intervals at the end of the 2 year. So the conclusion was Q16 treatment interval could be a rational treatment extension regime for a treatment strategy of DME. Jade et al. Study to investigate the safety and efficacy of aflibercept for DME. Improvement in BCA was noted from 58.3 at baseline to 66.6 at 52, a gain of 8.3 letters. The mean number of injections was 7.7. Patients who achieved disease stability was 87%, and patients with dry retina at 52 were 51%. 89%, 40 of 45 patients had a last injection interval of 12 weeks. So in summary, aflibercept can achieve a meaningful vision gains in patients with DME as demonstrated by the real RCTs, randomized clinical trials. Meta-analysis and international guidelines and recommendations suggest aflibercept should be the drug of choice when treating patients with baseline visual acuity of less than 69 letters, 20/40 or worse. The real-world evidence highlights the effectiveness of aflibercept in the clinic, where patients regularly present with poor baseline visual acuity of less than 69 letters. Patients with visual impairment due to DME, particularly those with baseline BCVA 20/40 or worse, can achieve meaningful vision gains with aflibercept compared with other anti-VEGF agents in real-world clinical practice. Thank you.
Thank you so much, sir. Is there any query regarding DME or anything? You can put in your chat. I think there is no query, but we can. What is your prefer? Sir, there is a query.
So the query is, what is your preferred drug of choice in naive patients? I specifically in the diabetic macular edema and other patients. See, aflibercept is one of the preferred drug of choice in treatment naive patients also. But it all depends. See, basically, if my practice depends mainly on the finances of the patient also. So if the patient is affording, I preferably go to aflibercept. The only reason is it acts acts on multiple targets compared to other molecules which acts on a single target. So it's more like a value for money drug now.
Thanks, sir, for addressing this question. I think no more questions, right? Sir, one question is there that after prioritization we are also starting. That is, of course,
Even they are agreeing to the same thing.
no problem. So thank you so much for this informative insight, sir.
Thank you so much.
Yeah. Technical team.
Yes, ma'am.
Yeah, I think sir has done with his topic discussion.